Okay, so thank you all for attending. This is our QOF Quick Wins webinar 24-25. Some of you may already know me, but my name's Billy Jo Caulfield. I'm the primary care facilitator for Newham and Barking and Dagenham. I also have my colleague Shazia here, who is the primary care facilitator for City and Hackney. I have our Anna, who is our senior primary care facilitator and childhood immunisation lead. And we also do have our other facilitators and primary care support officers here as well. So I'm just going to quickly run through them. So we have Tracy, who is the primary care facilitator for Redbridge and Havering. We have Lewis, who is also a primary care facilitator for City and Hackney. We have Mevish, who is our primary care support officer. We have Prit, who is the primary care facilitator for Wolverhampton Forest, and we have Toyin, who is the primary care facilitator for Tower Hamlets. So I just wanted everyone to be able to see a face to the name. We also have Dr. O'Hallahan here, who is our clinical lead, and he will also be in here. And we do have some of our other senior facilitators. So I just wanted to go over a quick of who the clinical effectiveness group are. So we are GPs, analysts, data scientists and facilitators, and we're based at Queen Mary University. We have access to primary care data across NEL. We build dashboards, searches and software tools for GPs and NHS commissioners and public health. We are facilitators and support officers. So this is which gives you one-to-one support. We also publish research for national and international significance, and we are funded by NHS and local authorities across NEL and research grants. So what we will be covering today, so just a quick QOF overview, then we'll be doing QOF end of year tips for you, and then what the CEG can offer, and this includes a QOF income maximiser. So just a quick overview of QOF. So the value of each point is 220.62. The total points are 632, and these are broke down in 3 areas. So you have your clinical indicators, quality improvement and public health. So I just wanted to go over a bit about income protection and prevalence. So of the 635 points, 220 points have been income protected this year. And these include 19 registers, 6 clinical indicators, 1 public health indicators, and 6 quality improvement indicators. We do provide prevalence improvement searches, which can help with your to help improve your prevalence. And obviously, when you're doing this in Q4, it does allow that you don't need to do any review, so it won't be any extra work for you. So these are the income protected indicators. So you have your registers in the dark blue and then your other indicators in the lighter blue. So whilst these points are income protected, payments are still subject to prevalence and list size. With this in mind, we do encourage that you continue working on your prevalence. So you can use our prevalence improvement searches for this. So, and there's a number of reasons why. So for patient care, so to make sure that they are correctly identified on the correct registers and getting the care that they need. Also increasing your income. So the larger your disease register, the higher the payment. And as I mentioned previously, this should not increase your workload, because if you're adding them in Q4, then this will they'll be excluded from the denominator, so you won't have to do the reviews until April. This is a quick overview of EMIS, QOF, and as you can see, you've got how am I driving, look ahead, and end of year. So we did want to make you aware that the end of year has been running at the same date as how am I driving. We noticed that recently. So what you can do is copy the support searches over and then run your end of year with a relevant run date for EMIS. It is affecting some of the medications that need to be issued within the last 6 months. Next slide, please. This is just, again, an overview of System 1. You can see on the left-hand side, they also have how am I driving and your end of year. Next slide. So now I'm going to pass you over to my colleague Shazia, who's going to look and take you through the quick wins.
Thank you, Billy Jo. Right, so our quick wins will consist of a list of practical steps to follow between now and end of year. We'll be focusing on the indicators that are still in place and not the income protected ones. We'll try to highlight some low hanging fruit, massive asterisk there. What we'll do is we'll clarify some tricky indicators where we commonly get a lot of questions. And then it's just going to be a general reminder of the available personalised care adjustment codes, which used to be known as exception codes. And just a reminder that you will be using these codes with caution whilst we will run you through the ones that are commonly available. Just a reminder that the expectation is that you will be able to deliver most of this activity. It's focused on the patient and delivering their care, but where you've got these exceptions, we will highlight the codes that you may need to use. Next slide, please. So first and foremost, and bear with me, some of these will be very, very basic, but this webinar is pitched at a basic to intermediate level. So all indicators should exempt patients from the denominator if you have evidenced 2 attempts to invite them for the activity in year. So that's as per QOF rules. I'll come back to the asterisk later. Invitations must be sent at least 7 days apart, and they need to be correctly coded. So you can review your patient records to update your invitation coding, particularly if you are using maybe one invitation code to invite the patient for multiple interventions. If you click, please. Mevish. And that's just a snapshot of what you see in EMIS. These invitation codes are very easy to find. You can see all I've typed in there is QOF invitation. And you'll get the whole list below. And I've just highlighted on the bottom right that in order to know that a code is QOF compliant, you will find the little yellow QOF box at the end of the code there. Just back to the asterisk for a second. So QOF mandates that you invite patients at least twice. However, for cervical screening, it is 3 times. Next slide, please. So coming back to cervical screening, this section is dedicated to reviewing external systems, so it might not be something that you naturally do. So when we talk about the cervical screening indicators 05 and 06, it is ensuring that the patient has an adequate smear within the appropriate time frame. A reminder that 2 invitations are being sent centrally across now, so it's on the practice to send the 3rd invitation. So before we talk about PCAs, let's talk about what else you can do. First and foremost, again, make sure that your coding is QOF compliant. It's only been in the last few years that you can actually see the QOF compliant box at the end of the code, so you may need to update your pregnancy or hysterectomy codes. Secondly, you may have been familiar with OpenExeter, which is now called the Cervical Screening Management System. This new system has taken over, and what you might want to do is batch download patient history. So there may be some codes that just have not come through to your system. Maybe the patient moved from another area of the country, another practice, GP to GP has failed, and you haven't got that result on your system. So it's well worth actually doing this on the system to see if there are any uncoded results. Just a caveat, I think you can only do 100 at a time by uploading NHS numbers, but there is a full guide available on the NHS digital website. There is a link in here, so when you get the slides afterwards, you will be able to access that. Next slide, please. Right, so now we can talk about the exceptions. You've got the typical exception, cervical smear not indicated, cervical smear refused or decline. You can have the no response to 3 invitations. So again, just going back to the mandate that you invite the patient 3 times, there is a specific code to say no response. And patients registered in Q4. So actually that's across all of the indicators. I haven't been explicit across all of the slides here, but patients registered in Q4 diagnosed in Q4 are likely to be accepted in the indicator. What we wanted to say was just a reminder, using PCAs in this domain, it's not the same as using it in every other domain. These exceptions carry across years. So if you use the not indicated, refused or declined for, say, a patient in cohort CS05, they will then be removed from your denominator for 3 years and 6 months. And for those in CS06, it will be 5 years and 6 months. So we do just want to highlight that to practices. You may not realize it, but just applying that code at the end of the year they're out of your searches for at least 3.5 years. Okay, next please. Right, so going back to reviewing external systems, so we spoke about the cervical smears management system. There are other electronic patient records that are available to you, and you can often find other information on there, such as blood pressure readings, HbA1c results. You know, if the patient is not coming to the GP practice, but they're happy to go to the hospital, you may find it on the hospital record. An example of some of these systems might be the HIE, also known as the Cerner portal. You may have a login for Epic Care if you're associated with UCLH, but again, all of these platforms may have a piece of the puzzle that you haven't yet managed to capture. Next, please. Right, now this is very, very basic. Just a reminder to review your system carefully. Check the patient record to ensure that you haven't missed coding any information. Now, we will try to code and capture the information at the time, but potentially patient documents can contain uncoded information. It might have the results of physical checks, say if they're diabetic under the care of the hospital, it'd have their blood pressure, height, weight, BMI, foot check, these kinds of things. You might have uncoded blood test results that are on your system. There's no codes associated with them. There may be evidence of discussions around medication. The patient has expressed that they decline. The discussion has happened, so it's easy to miss this within the documents. Additionally, it can also be found in the free text portion of the patient notes. So again, you might see a verbal invitation, ask the patient to come in for a smear, discussed a statin, this kind of thing. So you might actually have that information in the patient record already, just uncoded. So we do recommend that you go back and check that. Next, please. Low-hanging fruit, like I said, massive asterisk. Our definition here is that the effort required to fulfill the indicator is relatively low. You might have, say, for example, the income protected indicator for mental health, where you've got the 6 elements to be done. You've got a lot of work going into that in comparison to, say, AF06, which is patients with AF, and they've had their stroke risk calculated with the CHADS-VASc score. So it's very, very simple to do, particularly in EMIS, and I'm showing you that I work with EMIS mostly. So in EMIS, you can use our CEG template, likewise in System 1, actually. But additionally, in EMIS, you do have a little ZAP template at the side. So QOF EMIS provides this for you. It will say the patient is missing that calculation. You double click on it, it will launch the ZAP template, and you can calculate it that way. So that is all that is required for this indicator. So if you haven't achieved this one yet, hopefully you can go through and do that now. Then we've got the smoking indicators, smoke 02 and smoke 04. So that is patients with a chronic disease and their smoking status recorded, or current smokers with an offer of support given. So you might, if the patient was newly registered in year, you may have missed coding that from the registration form. So it's worth having a look back there. You can also message out in bulk. And again, huge asterisk here. I know that practices are now being charged for AccuRx, but if you have a particularly good database of emails and you have a little bit in your budget, you can bulk message out, email or text to the NHS app to try and get that information. The other thing I'll say is targeted recall. So this is a last thing, you know, that sometimes it can be a little bit difficult to call a patient in, but with smoking status, it's fairly sort of low grade information. A patient should be happy to share that over the phone. So it may be worth actually just working your way through a traditional recall list with this one. Next slide, please. So we talk about clarifying your denominators. So if you've got an inflated denominator or a reduced denominator, obviously that is going to affect your final achievement calculation. So let's talk, for example, about heart failure 03 and heart failure 06. This is about patients with heart failure, but their heart failure must be due to left-sided ventricular dysfunction or heart failure with reduced ejection fraction, and they should be on certain medications. Have you actually coded the classification of heart failure correctly? It may be that it's on the record, on the echocardiogram. You may have had this information on there, but you just haven't coded those additional elements. So again, something to consider. Then the other element here, so for DM33, DM22, DM20, which is diabetics with a blood pressure controlled to less than or equal to 140/90, or an HbA1c controlled to less than or equal to 58, or diabetics on a statin. Have you undertaken a frailty assessment? For those patients on the exceptions list, are they 65 plus? Have you done that frailty assessment and have you coded them correctly? Because if they have moderate or severe frailty, they will come out of the denominator for these indicators. However, They will then be added to the indicator DM21, which is the HbA1c control for patients with moderate or severe frailty, which is recommended to be less than or equal to 75. However, across all of these indicators, you do have certain declines and exceptions, which I'll talk you through on the next few slides. Next slide, please. So first and foremost, I want to impress upon you all, we have a template for it. You can see a snapshot of the City and Hackney EMIS template at the moment here. We have got a tab called QOF PCAs, all of the exceptions. We don't expect you to remember and code all of the codes that we'll show you in the presentation today, but just a reminder that they will be on the QOF PCA exceptions page. And if you are struggling with any of them, you can contact your local facilitator and we will support you with that. But that's what the EMIS template will look like. And obviously the System 1 template will look slightly different. Next slide, please. So, if patients have allergies, adverse reactions to medications, they decline any activity, all of this information should be coded because it will affect your denominator. We've got, for example, here, we've actually got some patients, some indicators where you can code that a patient is on maximal tolerated therapy. So, for example, maximal tolerated antihypertensive therapy, coded in year, will be accepted for CHD 15, CHD 16, hypertension 8, 9, diabetes 33. All of these indicators, you can actually code that the patient is on maximal tolerated antihypertensive therapy, and they will be removed from the denominator. Likewise, for maximal tolerated lipid-lowering therapy, again coded in financial year, that will be accepted for cholesterol 3 and cholesterol 4. Next slide, please. You've also got decline codes available for a few other indicators. This is not an exhaustive list. I must impress that upon you. It's not an exhaustive list. We've just cherry-picked a few of them where we've noticed that practices tend to struggle in these areas. So for NDH, non-diabetic hypoglycemia O2, MH12, you can code blood glucose test declined, and the patient again will come out of the denominator. MH11, cholesterol 04, you can say the cholesterol test was declined. MH03, BPO2, you can say that the blood pressure procedure was declined. So it's not just your standard PCAs that are there. There are also exceptions for patients who decline an activity. And then at the bottom of the slide here, you will see that, yes, you've got your standard QOF PCAs. They all follow the same format, excepted from whatever the indicator is, indicators, and you've got two variations of this. You can say the patient was unsuitable or that it was informed dissent. So you've got quite a few codes available to you here. Next slide, please. Tricky indicators. So we have queries about these indicators all the time, so we thought it might be helpful just to clarify what's going on here. So talking about asthma 11, that's patients who are newly diagnosed with asthma on or after the 1st of April 2023 with objective tests recorded. So what it requires, quality assured spirometry and another objective test within the following time frame. So if they're a regular patient of yours and you've newly diagnosed the asthma, you'll want to quality assure and confirm that diagnosis with spirometry and another objective test from 3 months before to 6 months after diagnosis. However, if the patient is newly registered in year, and I did note this was one of the queries that came in with the sign-up form, if the patient has registered with you and the previous practice didn't do it, you have got 6 months from the date of registration to actually do this piece of work. And then just a reminder of what the objective tests include. So there's FeNO testing, there's bronchodilator reversibility, all these peak flow measurement. Now I've highlighted peak flow measurement just because FeNO testing, a lot of practices say this is not available to us. Likewise, bronchodilator reversibility, we can't do that, but peak flow measurement should be within the capabilities of most practices, but it's overlooked quite a bit. So just a reminder that that is there. So I'd recommend if you've got any patients who are still within that correct time frame to go back and see if you can offer this intervention for them. Next slide, please. Exceptions to this. Again, I've already said it, but you've got informed dissent. You've got that the patient is unsuitable. You can actually code asthma monitoring refused or declined. Again, that will remove the patients from the denominator. Or if the spirometry service is not available, you do have the code to reflect this. QOF diagnostic spirometry service not available. Next slide, please. Asthma 07, asthma with review in the last 12 months. This one has been around for a very long time. It's not necessarily tricky, but it's just a reminder of the time frame between all of the codes. So you'll need to code that the asthma review was done in year. Then you need to code that the management plan was done. but you need to code that at the same date as the review. Then for the asthma control test score and the number of exacerbations, you've got at least 1 month before the review up to the date of the review to code that. So commonly what practices will do, they will book the patient in, they will send the Florey, they will say, can you fill this out? So they'll have that information on record, but it's ahead of the review. So you do have a little bit of leeway there. Next slide, please. Right, so this is the QOF atrial fibrillation indicator, and what I'm going to do is I'm going to ask our clinical lead, Dr. O'Hanlon, to explain this one to you all.
Hi everyone, so I'm just going to jump in here. Thanks, Shazia. We get quite a lot of questions about AF08 because this indicator looks at people with atrial fibrillation who have a CHA2DS2-VASc score of 2 or more, so are kind of at higher risk of stroke, who are prescribed anticoagulation. Now, the indicator, first of all, looks to see whether patients are on a DOAC, and it looks preferentially at DOACs over vitamin K antagonists like warfarin. So where we often get queries, we've got someone on warfarin, why aren't they included in the numerator? And actually the key bit here is if they're on a DOAC, they automatically go straight through. If they're on something like warfarin, you need to specify that there was a reason that they weren't on a DOAC. So either that they've declined it within the last 12 months, if they've got a code indicating that DOAC is contraindicated ever, that will automatically happen. If they happen to have antiphospholipid syndrome, or if they have a DOAC not indicated code within the last 12 months, you also need to code their warfarin time in therapeutic range, and that needs to be 65% or greater. Now, you may well have that in a document already, but it may well not be coded. So if you're finding you've got a patient on warfarin, you've coded that the DOAC wasn't indicated, you're wondering why they're not in there, just double check that you've got the time in therapeutic range. Now, this is for patients who have not had a mechanical heart valve replacement. For those who have had a mechanical heart valve replacement, the DOAC's not actually suitable. So it will automatically not assess for DOACs, and it will then just look at the warfarin prescribing. So if you've got a patient who has AF with a CHA2DS2-VASc score of 2 or more and has a coded mechanical valve replacement on the notes, as long as they're on warfarin, they had a prescription of that in the final 6 months of the year, they should go through automatically as well. Now, for those who don't want any anticoagulation, you can code individually that the DOAC was declined and warfarin was declined, or that both of them are unsuitable, but there are actually some overarching decline and contraindicated codes as well, so they're probably just easier to use. So there's anticoagulation declined, anticoagulation contraindicated, and anticoagulation not tolerated. That last one needs to be, and decline need to be entered each year, whereas anticoagulation contraindicated is a longer lasting contraindication. I'll hand back over to Shazia now.
Thanks, Mike. Next slide, please. So cholesterol, it's not really a tricky one, but it's just a reminder of the update that happened between the last contract year and this one. You've got your two indicators, cholesterol O3 and cholesterol O4, changed from cholesterol 1 and 2 last year. Cholesterol O3, patients on the coronary heart disease register, peripheral arterial disease, stroke TIA or CKD registers who are prescribed a statin or alternative lipid lowering therapy where a statin is declined or not clinically suitable. And cholesterol O4, you've got patients on the same registers apart from the CKD register who have a record of LDL cholesterol to less than or equal to 2 in the last 12 months, or in the absence of LDL and non-HDL cholesterol less than or equal to 2.6 in the last 12 months. So you can see that there's a huge change between last year and this year. These targets in cholesterol O4 have been aligned with the NICE guidelines. Previously, I believe they were less than 1.8 for the LDL cholesterol, less than 2.5 for the non-HDL, but you can see they've relaxed those thresholds a bit. Next slide, please. And then just a reminder, I've had these on another slide somewhere else, but if you do struggle with these domains, you've got exceptions that are mutual to both indicators. You can code maximal tolerated lipid lowering therapy in year, that will remove the patient, lipid lowering therapy not indicated, lipid lowering therapy declined, and as I've said before, if you do 2 coded invitations at least 7 days apart, the patients are removed from your denominator. Thank you. Now I'm going to hand over to my colleague Anna to discuss the QOF childhood immunizations domain.
Hello. Right, most of you will be quite familiar with these indicators by now. They've been around since 2021, I think, and you will be familiar with the difficulty. The the difficulty is that they focus on timeliness. So what happens here is that if you don't administer vaccination in time, it will not count. So if you vaccinate after the 8 months period, it won't count. If you give an MMR before the first birthday, even by 1 day, it will not count. If you give a preschool booster 1 day after a 5th birthday, it won't count. On the other hand, the DTaP dose, as it is defined, is really a DTaP IPV, but if there is no HAP or not HAP B, it still counts. So that's to encourage you to record vaccinations that may have been given abroad and that they are not like ours, which is a hexa. There is no PCAs that you can do that you can code. You cannot code decline. Well, you could, but it's not going to affect your QOF indicate your QOF achievement, except for contraindication codes, which are extremely rare. I mean, if someone starts seeing lots of contraindication codes in your record, they're going to come asking what's going on, because it will be very rare clinically. But the QOF searches do automatically exclude some children. So those are the fabled new PCAs that were introduced last year, and they exclude automatically from the denominator children who have registered too late for you to give them the vaccinations in time. Next slide, please. Right, these are very high value metrics, and unfortunately, you might not be able to do much at this point. We've got 2 tools available to help you. One is in our Apple IMS tool, where you've got in the contract section a QOF last chance filter, and if you click those filters, you will get a list of all the children who are just about to fall off the QOF cliff. So these are children where you can still do something, but if you leave it much later, you won't be able to do anything. So that's one of the tools. The other one is a data quality search that you can find in your clinical system, which is looking at children who have had their preschool booster coded with the wrong code. You might not think that you are susceptible to these because you are using an up-to-date template, CG template. However, perhaps the code was entered by a local healthcare professional, or perhaps it was entered in a previous surgery. So we do encourage you to go and check this search by the end of March. Next slide, please. Some questions that have come up recently, including in the registration form for this webinar, what are the decline codes? As I said, there are no decline codes that will accept your report from QOF. However, they are still very useful because it will help you with your recall systems. How can you go in and code vaccinations correctly in children records from elsewhere? Well, this is actually incredibly important. You do need to correct vaccinations that might not have been entered correctly in the past, or perhaps they were not even in the record because they were given abroad, or they might have come through from a different clinical system and they didn't incorporate correctly. So you have to check all these and use the CG template to code them. And the CG template actually has an extra page where you can enter vaccinations given abroad. If you're not sure how to do any of these, reach to your local CG facilitator and we'll be able to help you. Another question that came up recently is why are patients age over 5 still showing in the VI0003 searches? Well, this is because the denominator is actually comprised of patients who attained 5 years old during the service year. So everybody's going to be 5 years something. That's the denominator, whereas the numerator is the one that demands that the vaccination was given at less than 5 years of age. Another reason why you have to remember that for children vaccination, you cannot use the excluded list as your recall list. Use the Apple IMS tool instead. These are just very, very recent questions, but we get a lot of questions about childhood immunization and QOF because it's a quite difficult domain, and that is why we've got a whole several pages long document of frequently asked questions in our website, and you can access it whenever you want. And that's me. Thank you.
So we're going to go on to any questions now. We do have one question in the chat, Anna, which is about childhood IMS. They have been using the template to code their overseas, but it's not picking up through QOF.
Okay, and we would have to liaise directly with you to see exactly what codes they are. But I forgot to mention that there is a frequently used vaccination abroad that is not QOF compatible, unfortunately. It's the 5-in-1, but it's not like the 5-in-1 we used to have in this country, where it was everything minus hepatitis B. The one that is currently using quite a few Asian countries, if I remember correctly, is a 5-in-1 with no inactivated polio, and that is not recognized by QOF, I'm afraid. And we could go more into that in clinical terms. According to the algorithm of incomplete vaccinations, if someone has had this 5-in-1 and oral polio, you still have to give them the 3 hexas, because the oral polio is not protecting them from all the strains of polio. So they need to have inactivated polio as well. And the only way we can give them inactivated polio in this country at that age is through hexas. Is that quite clear? If it's not clear, we can discuss it further.
Yeah, they've got a thumbs up, so
Okay.
I think it's clear. There are quite a few other ones that have got queries for childhood IMS as well. Do we know when the points for the childhood IMS indicator will kick in? Because they're currently sitting at 86%, but the scoring point is still 0 out of 18 points. So I'm not sure when that would kick in for a QOF.
That doesn't sound right. I don't understand why that would be. It's supposed to have kicked it. Or sorry, where's it? 84 to 86. Oh, hold on. Right, it depends. Sorry, I was reading the question wrong. It depends on what the lower target is, and they don't all have the same lower target. Unfortunately, I don't have it in my mind straight away what the lower target is, but I can check it while someone else is answering other questions.
I've actually got it up, Anna.
Oh, have you? Brilliant.
Yeah, so for VI001, the lower target is 89%, VI02, it's 86%, and VI03, it's 81%. So depending on which target you're referring to, Bogish, those are the lower thresholds, but you'll find them in the QOF guidance. We've got thank you. Sorry, go on, Billy Joe.
Oh, I can see the next one.
Yeah.
I'm adding 5-in-1 and separate IPV. I'm afraid this separate IPV is not in the business rules. The minimum unit in the business rules is 3. Is is the DTAP IPV.
Perfect.
So what percentage of the eligible population can we apply the exception codes for cervical screening? Is it 10%?
I don't think there is.
There isn't one. I mean, we always caution you against this because there is this popular tale of if your exception reporting rate is too high, not CQRS, why am I calling them CQRS? CQC will question those figures. So with some of these, you're not actually deliberately applying that code. You are just doing exactly as the QOF guidance says, which is no response to 3 invitations, you're coding that, but we can't actually give you a hard threshold. Like I've said, I've heard anecdotally 10% is the point at which it will raise a question, but only CQC can really answer that for you. But that is really up to your judgment and what you feel that you can defend as well. If you have been inviting, you've done everything to the letter of the guidance, you've tried your best, you will have to explain that to CQRS if CQC again if they do question that.
We've got a couple of hands up, so I'm just going to ask them to unmute themselves. So Andrea, do you want to go first? If you unmute your mic.
Yes, thank you. Thank you. I do have a question actually about the red books that come from abroad. Yeah. Some people, they don't translate it, and I wish I could code myself, but I don't understand that language. And I was speaking with Susan, which is the lead, but she said there is not actually a mean any means, I mean, in across Redbridge that will translate it for us. And one of the things that they've written in the email, which I saw, was translate on Google Translate. But that is about clinical safety. I don't take the risk to be that on my name. So
Yeah, I can see your predicament. I can perfectly understand it. There is a link that we've got in our templates and in our tool, which takes you to a spreadsheet that compares them, that compares different. Do we still have that? I hope I'm
Yeah, we do.
saying this. We do, haven't we? And in
And
this
it's on the
one,
APL tool as well.
and if I remember correctly, you can see both the English and the foreign language vaccination on the same row. I'll see if I can bring one up.
there was a language which I wouldn't understand, and somebody told me it's in Bangladeshi, but
Sorry, we can't
Sorry.
hear you clearly.
can you hear me?
All right,
Yeah,
yes,
can hear you better now.
So at some point I was asking what language is this in, because I couldn't even understand the language, how it was looking something Arabic to me, and they said it's in Bangladeshi. But if we don't have any mean, like, an official one that will translate for us, I find it difficult to do it, and as well to take this clinical responsibility on my shoulders.
There is something else, and is that even the QOF guidance book says that you can talk to the parents. So if the parents are showing you something, they are telling you from which country they are, and you can bring up you can actually Google, you've got these what do you call them, vaccination schedules from abroad, and they will show you what they have, and you can actually follow it. It's not simple. It's not something. It's something that takes time, but you can actually see it. That's all I can.
So there is no official tool yet. Even if they are this strict on immunization, there is no official tool to help
To translate,
practice.
not to
Yeah.
translate. No. I mean, usually you would have your health, practice translators or health advocates. I'm not
Yeah,
sure if
but
you still have.
that will be verbal. But if I don't understand the language, how I would be able to read it to them?
Okay, so yeah, so you would need to they would have to be present in the practice. Yes, that's correct. And the parents
Well,
will
that
have to
is a
deliver.
good idea for future, for next QOF year, in case they want to pick it up. Thank you.
Knuckle?
Thanks, Billy Jo. I had a question for Michael, actually, just regarding the AF indicator. Michael, could you just run that by me again? Because I've got about 4 or 5 patients that are actually on warfarin that are in the excluded list. So my understanding from what you mentioned, just want to clarify with you, is that, first of all, it's looking for a clinical code to say that a DARAC is contraindicated, and that might then bring them into the included list. Or if that's there, I need to enter an INR timing range. Is that correct?
Yeah. So if they have declined, so first of all, if they don't have mechanical valve replacement, it will look to see have they had a DOAC prescribed in the last 6 months. If they haven't, it will look to see are they on warfarin and do they have something else. So a DOAC declined code in DOAC contraindicated code ever, or if you're saying a DOAC is not indicated, you have to put the time and therapeutic range in there. So it may well be that those patients don't have the time and therapeutic range coded. That also has to be coded within the last 6 months of the year, and the prescription has to be within the last 6 months of the year as well. So they would kind of be the 2 things I would say to check. If you are still having patients, and this goes to everyone here, if you're having any patients for this indicator or any other indicators that you can't quite work out, these people should be included in the numerator, why aren't they coming up? Please do just reach out to your local facilitators. We are more than happy to try and help you troubleshoot, to try and help you achieve as much of the indicator as you can.
Okay, thank you. So basically, I'll check for a DOAC contraindication code first. We don't typically get INR timing range information, so that I guess I'll have to reach out to the anti-coag clinic to get that. I think their software calculates that.
Their software calculates that, yeah. So it may well be included in letters from the anti-coag clinic. So yeah, if you have a list of those people, it may be worth kind of building that up and then contact the anti-coag clinic kind of en masse for those. And it just needs to be from within the last 6 months of the year. Yeah.
Okay, brilliant. Thank you.
No problem.
We did just have another hand up. I think Rosalind's put a hand down now. We do have some other questions in the chat, so we'll probably just answer a couple of these. So invitation codes for cholesterol 03, Shazia?
Yep, so what I'll do is I've got these codes. I'm just going to pop them in the chat here.
Yep.
And we can include them after, but those are the invitation codes that you can use for cholesterol. And then just back to the question from Aisha, is there any code we can use for patients who are abroad and back after March? Unfortunately not. If they are not with you, it is the practice decision as to how you treat these patients. Have they been with you for a long time, or have they been abroad for a long time, in which case you may consider that they are not under the care of your practice, you can't provide effective care for them, or is it that it's just a little short-term trip? So I would say there isn't a code available for this, and that is up to the practice.
Okay, so there are quite a few questions about diabetes in the chat. So we have about diabetes if they're unable to have the HbA1c, and then they will have their alternative test. Also regarding foot checks and patients with diabetes in remissions, alert says foot checks needed. So there are a couple.
Okay, so with regard to the diabetic patients who need a fructosamine test, I've been looking at the rules. If they have a fructosamine in year and they do not have an HbA1c, they are out. So they will come out of the QOF denominator if they've got fructosamine on record and they don't have an HbA1c on there. And then just regarding foot checks for patients who are in remission, Mike, I might sort of look your way as to whether this is clinically indicated. It might not be something on your mind, but I think that is up to the clinical lead within the practice. If that's something that you need to offer them, then you need to offer them. Otherwise, potentially those patients are unsuitable and need to be coded as such. Sorry, Mike, you've unmuted yourself.
We can double check in the business rules, but I was under the impression once you've got a kind of in remission code that you necessarily need to do that, but I can double check that and get back to you.
Thank you, Mike. And also about the frailty assessment. So you can use our template to do frailty assessments. So all of our LTC templates, they are available for you to do that assessment and then code them if they're moderate or severe or mild frailty. And then that will either remove them or it will put them, like for the HbA1c, as Shazia said, it will take them into the next indicator where the HbA1c can be under 75 instead of 58.
With regards to how to undertake a frailty assessment as well, there is the Rockwood Frailty Score as well. If you Google it, there is a chart which gives what score means what thing. So you can then kind of assess the patient and determine how frail they are.
Should also be linked on the LTC template as well. You should have a specific frailty page with that on there. Does the frailty code need to be added before the HbA1c result, or would it exclude if added at the time of reviewing the result? So I assume this goes back to the diabetes indicator. What the rules do is I think they act independently of when the result is in. So if they are moderate or severely frail, then it would classify them accordingly. So I don't think there is a connection with the time frame there.
There are quite a few other questions, but we will be doing some frequently asked questions sheet. But are there any that you want to pick out, Shazia or Mike, that are quite urgent? But I am keep checking the time as we have got quite a few more bits to cover as well. But there are a few diabetes ones, so I think we should add all of them onto our Q&As.
Yep.
I'm just looking through some of them.
Yeah, just looking at these briefly, I can ask about stroke 007. We only have 4 patients on that list, but we are not sure what we need to do. So first and foremost, I'd point you to the QOF guidance, because that will give you a brief and actually a detailed explanation as well of what's required for the indicator. But for those patients, you are looking to prescribe them an antiplatelet or an anticoagulant in the last 6 months of the year. I'm sure there's some fun coding on here in terms of exceptions and things, but I would just say that's the spirit of the indicator. It's looking for a prescription in the last 6 months. If you do struggle, get back to your local facilitator and we'll be able to give you some further guidance.
If a HbA1c is not within the QOF range of 71 and below, wherein it's slightly off. I'm not sure. That's Rosalind. If you could pop on and just go over that question, please.
Don't worry if you're unable to. If it's out of range, then it's out of range. You need to focus on the control of that patient. I may have added a slide earlier where the patient was on maximal tolerated and he, where is it gone? No, that's antihypertensive. Potentially not, but if your patient is out of range, you can only focus on getting them in range or considering one of the exclusions.
Okay. Thank you all for your questions. If we have missed any of the questions, then we will put these in our frequently asked questions sheet that will get sent out to everybody as well, or we'll try and answer them as we go along. Maybe do you want to move on to the next slide, please? So this is back to you, Anna.
Yes, thank you. Income, how to maximize your income in QOF. System 1 is very good at this. We showed you before where you can see the end of year and how I'm driving, but what we didn't talk about is that you can also go to indicator values and to target patients. So indicator values is going to tell you how many points you've got available for each metric, what those points mean in terms of pounds, how many patients do you still have to do to meet the maximum target, and what is the fallout in the gap in terms of pounds. So that's incredibly useful. And on the target patients, you can even see which patients are the most valuable across all the indicators. Next slide, please. Now we IMI's practice, we're losing out on this. It's not something that they have. So we have been working in a QOF income maximizer report that is going to do a similar thing for IMI's practices. So what we're doing is we're running your QOF data and analyzing it to show you where you still need to do more work to meet your target, how many pages you have to do, what kind of work is outstanding, which domains, how much money there is to be made, and where your high value patients, but we haven't got as sophisticated as System 1 yet. We haven't been able to combine the different metrics. This is a kind of report that we would like to improve in the future. Well, not so much improve as build upon, and maybe start doing it for things like prevalence improvement, local enhanced services, but watch this space. So soon your practice manager will be receiving an email with a hyperlink to access the report and a unique practice code that is anonymized and unique to your practice, so that you can access it. Next slide, please. So the first part that you will see is one graph where it draws your attention to where there is more work to do. It's clear that in this particular practice there is still some work to do in diabetes and in hypertension, just as at a glance. It also says that you can earn up to £16,000 more by treating over 500 patients. There are some caveats to this, but this is just like a sort of like headline figure. And it also shows you when the data was extracted, which was the 11th of February. Next slide, please. The next graph is the one that draws attention not to where there is a patient gap, as we call it, but where there is an income gap. And whereas the biggest patient gaps were in diabetes and hypertension, the dementia patient gap, for instance, was very small, but actually the pounds gap was quite much bigger. So as you can see, there is quite the number of patients doesn't equal the number of pounds across the domain. So that's where this graph helps you at a glance. Next slide, please. And the third part of the report is an interactive table where all the metrics are sorted, are listed, and you can sort them by different categories, alphabetically, by difficulty, by clinical domain, by how much money you are currently making, by how many patients you have left to do, by patient value, and by total value, money gap, money remaining to be made for that particular metric. So in this case, in the screenshot above, we saw that some diabetes, hypertension, and cholesterol domains have got the most patients to do. But if we order it by patient value, this changes slightly. There is still a very valuable patient in diabetes, but strangely enough, is not the same metric. Or we've got, of course, our few dementia patients as well. I've glossed over a bit about the vaccination domains, because very often they are going to come up as high patient value, but unfortunately you are not always going to be able to get over the threshold with these ones. Next slide, please. There is a series of caveats, things that you have to bear in mind is that the calculations are not going to be 100% accurate, because we have to calculate your adjusted disease prevalence on the basis of last year's, because nobody knows what this year is going to be like on 31st of March 2025. The data is static, and as the weeks go by, your registers, denominators, numerators will change. We have not included most of the public health indicators or the income protected metrics. So this is just to give you an overview of where to sort of focus your efforts. It's not going to be something that you go back constantly. The patient, just remember as well that the patient gap shown is to meet the maximum target, not 100%. So clinically, you could still be working even if you have no patient gap. The patient gap is rounded up. There is no half patient. So if you've got half a patient to meet a target, QOF is not going to say that you've met the maximum target. You will have to do an extra patient. There are two ways of closing the gap, as we have seen. One is carrying out an activity, the other one is exception reporting. As we said already, sometimes closing the gap will not be possible because the activity needed to happen within a certain period of time. However, sometimes this can be an issue with data quality rather than lack of activity. So it's always worth to go back to it to see if there's something you can do. And don't try to compare these closely with your EMIS end of year QOF, because your EMIS end of year QOF will be changing every day. This is a static snapshot, and also the EMIS QOF end of year QOF has got some issues with medication, not just with medications, also with ages. We found, for example, that when we run our own QOF searches with a relative run date 1st of April, we pick up patients that will become 45 in February and March as in the denominator for the blood pressure indicator, but EMIS was not getting them, even though they were 44 and almost 45. And that is me for now. Any questions?
Thank you, Anna. There is just one question about when this will be available.
Very soon.
And the practices will receive an individual email, won't
Yes,
they?
that's right. Yes, that's right.
Yeah. There isn't any other questions regarding the maximizer. So I'm just going to quickly run through what the CEG can offer. So most of you probably already know what we offer, but just for those that don't, we offer practice support visits. So these can be annual visits. These can be with new users, APL training, resource MOTs. We also provide practice support searches. We have our CEG templates and protocols, which are your pop-up alerts. We provide monthly, quarterly dashboards. We also have our APL tools. So these are our renal tools, cancer audit tool, childhood IMS recall tool, AF tool, and national diabetes prevention tool. We provide drop-in sessions. So these can be either weekly, fortnightly, or monthly. And we also provide webinars. Next slide, please. So this is just a quick snapshot. So our support searches, you can see our folder structures here. So at the top on the left-hand side, you have your EMIS folders. And then on the bottom left-hand side, you have your System 1 support search folders. And then here we have our CEG templates. So these are just a few of our CEG templates that we offer. Most of you will be aware of the LTC and use that majority of the time, but just be aware that sometimes the names may be slightly different depending on the locality as well. Next slide, please. This is our weekly e-bulletin. So we send out a weekly e-bulletin to all the practices. We put sometimes nil information on here. We put if there's any webinars or any updates to our documents, templates, or searches. If you would like to be added to this, then please do contact your local facilitator and we can add you to the mailing list for this. Next slide, please. And our drop-in sessions. So just a little bit about our drop-in sessions. We do a variety of different things. So we usually go through our e-bulletin updates. Sometimes we do demos of APL tools, local updates or focused areas, and any queries from practices. But these are usually run by the practices that do attend. So if there is something that they want to go over, then we will go over it within the sessions. Again, if you're not signed up for these, then please do contact your local facilitator and we'll make sure that you're added onto the invite for these. Next slide, please. This is just your local practice support team. So all the email addresses that you would need for each locality, and there is a QR code there as well that you can access for all of this information as well. And then the next slide is all your QOF resources.